Hey guys, this is the first of a series of videos that I'm going to do on the viral hepatitis or hepatitis viruses. Typically when I talk about something in a group that way, the adenoviruses or whatever, they're all adenoviruses. And the same actually can't be said for the hepatitis viruses. The hepatitis viruses actually vary in their viral family and in their genome structure. But what they actually all have in common is the way they affect the liver. Most of the conditions we associate with hepatitis viruses or hepatitis are broken into acute hepatitis or chronic hepatitis. Some viruses can only cause acute, some viruses can cause acute or chronic, and some of them can cause even fulminant hepatitis, which would basically cause you to go into full liver failure. Incubation period for acute viral hepatitis can range based on the virus that's causing it from anywhere from 15 to about 180 days. And there are three phases that we associate with all of them. The first is just kind of a prodromal phase. That is pretty similar to any other viral infection. It's malaise, low-grade fever, rash, arthralgia, things like that. Then you have what's known as the pre-icteric phase. This is basically characterized by anorexia, nausea, and vomiting, and headache, and food aversion, and some right upper quadrant pain as that liver begins to get involved, and diarrhea. Then you hit the icteric phase, and this is where the liver is fully involved. And in this phase, you have dark urine, clay-colored stools, which then progresses to overt jaundice. So when we think about patients being kind of a yellow color. In this video, I'm specifically going to talk about two hepatitis viruses, HAV, which is often known as infectious hepatitis, which is kind of a terrible name because technically all of the hepatitis viruses are infectious hepatitis virus. And then HEV, which is sometimes referred to as enteric hepatitis or non-A, non-B. So really kind of terrible names for these guys. In the US, most infections are caused by either HAV, BV, or CV, and they can all produce an acute illness characterized by, this prodromal phase. Globally, about 1.4 million and 20 million are infected each year with either HAV or HEV. And if we think about HBV and HCV, we think more in the millions as well, where about 1 million die each year. And like I said before, each virus is capable of infecting liver cells and causing significant damage there. So let's talk more specifically about HAV virus first. So this slide is actually for HAV, okay? HAV is a picornavirus, and like all the other picornaviruses, it has an RNA genome. It's largely spread by the fecal-oral route, which makes us worry about children, daycare workers, close contacts of patients who have been identified as having HAV, but we also associate it with ingesting contaminated food, particularly shellfish tends to get a bad rap for this one. The incubation period for this one is pretty variable, but it can be long, anywhere from 2 weeks to 2 months post-exposure. It has a really abrupt onset of icteric symptoms, so that prodromal phase is very short and just all of a sudden we're at icterus, but it doesn't lead to a chronic liver disease. This one is more acute. And the good news is there's no need for anyone to get this because there is an effective vaccine. So let's talk a little bit about the structure. It's a picornavirus, so it's very small. It does have an icosahedral capsid, which surrounds a positive sense single-stranded RNA. There's only one serotype of HAV, which is part of the reason the vaccine is so effective. And one of the things I'll mention is that it's not cytolytic. So when it actually is leaving the cell, which I'm not showing here, it actually just kind of buds off. So it's not killing the cell with lysis as it goes. So how does it kill the cell? Well, this is one of those viruses where disease is actually all about how we respond to it. The HAV viral response can actually be very damaging in this case. So typically, HAV is ingested, typically in either shellfish or contaminated material, and it enters the bloodstream through the epithelial lining of either the oropharynx or the intestines. Its main target is going to be the parenchyma cells of the liver, so basically hepatocytes. And the virus is going to replicate in the hepatocytes and Kupffer cells. The virus produced in these cells is then released into the bile and from there into the stool. So that's part of why we get this fecal oral route. The virus is shed in a pretty large quantity in the stool, approximately 10 days before the patient becomes icteric. So that means the patient is infectious before they're actually exhibiting symptoms or antibody can be detected. The nice thing is, and I'm kind of showing it here, so if we have this viral infected cell, one of the first things that actually winds up happening to promote stalling this reaction is interferon. Okay, so you have type 1 interferons, and then you also, although it doesn't look like they're listing them here, you also have some type 2 interferon, which is interferon gamma. And that's actually going to be what limits the viral replication. Because remember, those type 1 interferons are essentially the SOS signal. They tell all of the surrounding cells, downregulate expression of receptors, increase expression of MHC class 1, and stop creating new proteins. The other thing that's going to come in here is CTLs through IL-12 and interferon produced by nearby CD4 positive T cells, and then NK cells. And these are going to be really effective at identifying virally infected cells and basically killing them. And that's actually what leads to hepatocyte death during HIV infection. You can also see ADCC, antibody-dependent cell-mediated cytotoxicity, as a result of the NK cells and the antibodies working together. Anytime you have antibodies, you also want to think about the potential for complement. And in this case, complement is going to help with also the neutralizing antibody effect of basically identifying some of those virions and removing them so that they can't cause disease. Icterus and jaundice from liver damage actually occurs when that cell-mediated immune response and antibody to the virus peak. But the good news is most people are going to recover, and the antibodies here are neutralizing, and once you have experienced HIV, you are unlikely to get it again because it's protective for life, and it does not lead to chronic infection. Okay, so what are the clinical syndromes? So as I mentioned before, it's spread through the fecal-oral route, primarily a close personal contact with an infected person during foodborne outbreaks, shellfish, contaminated water, or other things. The other groups of people that we sometimes worry about are international travelers, and men who have sex with men, and non-injection and injection drug users. Both groups tend to have a higher rate of HIV, and also just children in communities with high risk for increased disease. So all of this clinical syndrome pretty much is caused by the immunopathogenesis to the disease. So because of that, you can actually just think of a normal immune response, and then you're going to be able to put it together with the timeline of the syndrome, okay? So if the virus is first detected in the liver and biopsies and feces somewhere about 2 weeks post-infection, we're actually looking for when these antibodies come up. So somewhere between 4 weeks and 6 weeks is when we hit that peak antibody. And when we see a lot of virus, that's when we're also going to see CD8s come up. So symptoms occur abruptly 15 to 50 days post-exposure, and then they're going to intensify for about a week while your body gets it under control. Before the icteric phase kind of concludes. It can last as long as 2 months, but normally that's about how long it takes. Jaundice is observed in about 70 to 80% of patients. The good news is, though, that fulminant hepatitis is pretty rare, really only occurs in 1 to 3 out of every 1,000 people. But when it does occur, it's pretty fatal. There's about an 80% mortality rate. So how are we going to diagnose it? If you're looking for acute viral hepatitis, one of the first things you're going to look for is increased ALT and AST. That usually ranges from about 4 to 8 weeks after exposure. The peak of transaminitis is usually during the time of jaundice, because that's kind of a good indicator that things aren't working well. And jaundice is usually evident once the bilirubin reaches 2.5 milligrams per deciliter, but it can rise to a peak of like 20 milligrams. The other thing we can look for is serology. When acute viral hepatitis is suspected, serologies should be sent to evaluate which virus, if any, is causing the disease. So for hepatitis A, you're going to look for HAV IgM, which will typically peak about 2 weeks after exposure, and then HAV IgG, that's going to show up longer than 2 weeks. Now, that said, if your patient was vaccinated for HAV, this will be up anyway, but then you're also probably not thinking that it was HAV. So how do we avoid it? There is a great vaccine. It's given at about 2 years of age. It consists of viral particles purified from infected cultured cells, which were inactivated with formaldehyde. So it is an inactivated vaccine, and we are recommended to give it to newborns up to 2 years old in all 50 states. You can give HIV immunoglobulin kind of as prophylaxis if you think your patient is ill. There aren't any current antiviral drugs for HIV, and the best way to avoid it is proper hand washing, especially in daycare centers, mental hospitals, medical facilities, and other care facilities. And then chlorine treatment of drinking water is generally sufficient to kill the virus. So that's one way to purify our water supply against it. Okay, now we're going to talk about hepatitis E virus. The reason I chose to put these two together is that they both are actually causes of acute hepatitis, and both infectious and have a similar route of infection, both fecal oral, and they don't tend to lead to fulminant hepatitis, although HEV is more likely to do so than HAV, and they neither of them actually leads to chronic hepatitis. So this is an enteric encapsulated RNA virus. The disease resembles HAV in that it is acute, self-limited, and typically a little bit less severe than some of the other ones. It's transmitted fecal oral, as we talked about before. Typically contaminated water is a big one for this one. But any of the other ways you would typically get HAV, you could also get HEV. It is unique in that it actually resembles a calcivirus. So the calciviridae would be things like norovirus. The symptoms and course of HEV are really similar to those of HAV, and it only causes acute disease. The incubation period is anywhere from 2 weeks to 2 months, also similar to HAV. And then once again, you get this abrupt onset of icteric symptoms. And really the thing that we worry about with HAV is pregnant women. For most people, this isn't going to be that big a deal, but in pregnant women, this one is actually a pretty significant concern. In most patients, the mortality rate of HEV is only about 1 to 2%, and that's still actually higher than HAV. It's about 10 times higher than HAV, but HEV is especially serious in pregnant women, where it has a mortality rate of 20%. And that's due to its ability to cause fulminant hepatitis. HEV has a higher potential to cause fulminant hepatitis than HAV, as you might imagine. And we're going to just diagnose it by the presence of IgG for HEV. There's no vaccine, no specific treatment. You just kind of gotta let the body clear it. So HAV and HEV are our acute hepatitis viruses. They can lead to fulminant hepatitis, but really we're worried about fulminant hepatitis in pregnant women infected with HEV. HAV has a vaccine, EV does not, and you get it through fecal oral route.